earlier on, I was in conversation with the CDO for England, and we're now going to show you what she had to say to me. And she's been putting in incredible hours for months now, so it's very decent of her to give up her time for conference. So can we go ahead to see the conversation with Sara Hurley, please? Thank you very much for taking the time to come and speak to LDC Conference, Sara. And I know there's a lot of people here really looking forward to hearing from you. So your role of CDO has gained increased prominence during this pandemic, but I think there's been some confusion on some fronts as to where your responsibilities lie. So I was just wondering, before we get started, could you tell us in a nutshell what is your remit, and conversely, what is not within your authority?
I absolutely recognise there's confusion, and I think the different structures of health for Scotland, Wales and Ireland and England don't help. But in a nutshell, my role is advisory, principally advisory to Her Majesty's Government on oral health in England. I advise NHS England on what services should be commissioned to support improving oral health, and we do that with commissioning standards. We also interact with Health Education England and also with Public Health England. So in a nutshell, national strategy, operational support and patient safety. Those are the three key things which we advise on and support.
Oh, great. So I know at the moment the whole profession is on tenterhooks wondering what the financial package is going to be for NHS dentistry. And I believe that you've worked hard to get the current financial arrangements in place. So I was just wondering what your hopes were for post-September.
Two things. I'm certainly not going to take the credit for all the arrangements. There's been a whole team of people and negotiators from the profession as well as our side. And perhaps it's worth saying what my role as CDO isn't. I don't own contracts, I don't set UDA rates, and I don't set tariffs. But I do, again, advise on what are the contract arrangements that will enable the profession to do what it does best. And I certainly have used the COVID opportunity that we've got to be able to fashion and shape an expectation that we can move away from UDAs and that we can focus on doing prevention, we can focus on the priority groups, and we can focus on health inequality. We're on the cusp of something quite exciting here, and I know that the BDA and the LDC representation at regional level, the positive collaboration, has really helped us put the arguments to Whitehall, to NHS England and to regional directors. And I think this collaboration is going to shape as we move forward. My hope is that we don't have to revert back to UDA treadmill, that we don't count widgets, that we can move to a system where we can measure health outcomes for patients. And I think there's a whole range of things that could be measured, but we want the profession's engagement on that. And I'm acutely aware that at regional level and with the BDA, the discussion on those metrics is there. We've got an opportunity, certainly between now and September and then through until Christmas, to really show what the profession can do when we've had the straitjacket of UDAs removed from us.
Yeah, I think the profession will be really pleased to get rid of UDAs, that's for sure.
Yeah.
So have you given any thought to private dentistry in all of this?
So private dentistry is all part of patient choice and is a feature of the landscape. And long may private dentistry work hand in hand with our practitioners, be it in the mixed practices or alongside our entirely NHS contract holders. I'm concerned about the sustainability of all practices and acutely aware that many of our NHS contract holders also have private commitments. And you may or may not be aware that prior to taking up his role as Deputy CDO, I invited Jason Wong to pull together an independent group to produce a report. And the key question is there any viability to the statement that in 18 months' time there's going to be a dearth of dental practices on the high street? So I know that Jason and all the stakeholders from DCPs, dental technicians, the NASDAL, our accountants, they've all input into that report. Now that report is by them, independent. It comes to me, and then at that point I will be taking it to Joe Churchill, who is also interested in the sustainability of all practices, because we all contribute to patient health. That's the dialogue and that's the discussion. It's done in a courteous way, to make sure that we got Joe's attention, we got Matt Hancock's attention, but actually the real attention has to be from the Chancellor, because of much of the changes that are going to be recommended, I suspect, will be about Treasury commitment as opposed to NHS England or Department of Health commitment.
All right, well, thanks for that. We'll change the subject now a bit because I know that you provide guidance to regional commissioners, and the guidance you give, you described it as being a handrail rather than a prescription, so you can't micromanage what the regions do. But I was wondering, how can we as LDCs ensure that our commissioners implement your guidance to the best effect?
So we think about the commissioning standards as being a quality benchmark. It's what you should be doing in terms of the commissioning. So whether it's commissioning conscious sedation, whether it's commissioning domiciliary services, so it's what good should look like, and the development of it has practitioners involved in it from the word go. When that goes out to the regional commissioners, first of all, there has got to be the demonstration that there is a need. So whether it's the need for conscious sedation, whether it's the need for domiciliary, whether it's the need for outreach projects, as we did with Starting Well, I think it's the voice of the LDC in being able to be advocates for the population and patients. This is what our patients are telling us they need. Here is the evidence of need. And from COVID, we've got a new perspective. Certainly all the feedback from the regional commissioners and the regional directors is they've recognised the collaboration between the LDC and the LDNs in bringing about changes of basically getting on and doing it under really difficult circumstances, managing the PPE shortages and being able to deliver an urgent dental care network. That is what we must build on, and the LDCs as advocates for patients and the need, and being able to say why oral health fits into a diabetes healthcare program, where oral health can fit into support in a special educational school setting. So it's being advocates for patients. And I think we need to recognise that the money for health programs sits now at regional level. If you want a health improvement program, there is no reason why oral health can't be part of that program. And that, I'm going to use the phrase, that's the bandwagon that we need to jump on. And we've got the credibility to do that now. And the LDCs have bought that credibility through the extraordinary endeavours that we've seen with the urgent dental care response to COVID. Okay. It's great news.
All right, thanks. So I wanted to comment on how often you've noted how appreciative you have been of our profession during the response to this crisis. And a theme in a lot of your communications with us is how you trust in our clinical judgment. And you've actually pointed out, I'll quote here, the wisdom of the clinical leadership in every practice. So does this trust herald a new era where you'll support us more to use our own clinical discretion?
I think from the day I arrived in this job, I've always talked about trust in the clinical judgment and trust in the professional leadership. That's not changed. If it's become more evident, then clearly I've got to think about having not communicated that trust particularly well in previous years. But the trust has been there. And I think the trust has also been picked up by the regulators. And we're seeing a lot more light touch, right touch from the regulators. The trust that we have in the profession and the trust that the regional commissioners can see that I have in the profession, I think is what has underpinned this opportunity now to move away from the UDA widgets, and we're trusting practice teams to be able to fulfill the required sort of patient volume as opposed to the UDA by doing the right things in the right way. I think one of the other areas of trust is trust in the practices handing on the NHS package, which was intended to sustain their practices and to sustain their staff. And you know, my great thanks to what is 98% of the profession that is absolutely honouring that commitment to their staff and have been passing on to associates, DCPs and indeed locum staff. But there are one or two practices, and I have letters in daily from associates, from locums and from dental nurses, where the sense of equity and fair play has not necessarily been fully honoured. And I think the LDC have a role in ensuring that the trust in the profession is also transferred to the trust in our teams, the DCPs, the associates. That's going to be key. Demonstrate the trust works to your teams, and that will be something that will pay dividends for us in the trust that NHS continues to place in us.
All right, thanks for that. So I think in previous correspondence, you've mentioned that the COVID-19 epidemic presents a potential for a determined revision to the current activity-driven clinical approach. So I was just wondering what your vision was for NHS dentistry as we move out of this crisis.
So you kindly referred to the article that was put into the BDJ, and I suppose it was a useful little warmer. People will recognise that it was put in the BDJ in early May. That sort of was heralding some of the shifts that perhaps we weren't able to say out loud. It didn't take a lot for people to read between the lines. But that talks about, again, moving away from UDA, moving away to a system that is looking at patient outcomes. It's also utilising the clinical philosophy, and I bow to the expertise of Avi Banerjee here, and also the work that Jimmy Steele put in 2009. I'm not reinventing the wheel. The wheel was already there because Jimmy gave us the wheel. This just happens to be an opportunity when the stars are aligning. There are a myriad of reasons why oral health doesn't sit on anyone else's priority list, but it's certainly now got visibility. And I think that the opportunity to really reap the dividends of moving away from UDAs that we've got in the next couple of months is what Jimmy would have wanted. And we've given you the toolkit in the SOP, in the standard operating procedure, and the annexes at the back produced by wet-fingered dentists on how you manage COVID, patient flow, and doing the prevention, the stabilisation, everything that we were taught to do without the pressures of UDAs.
Mm. In the SOPs that have been produced, it doesn't mention what's going to happen after when the COVID alert from the government goes down to a level 2. Why is that?
So I have to wait for the information to come out of SAGE, a nerve tag. I have to wait for it to go through Public Health England, and with the novel virus as it is, understanding what level 2 looks like and what limitations, restrictions can be lifted is still under discussion. I translate from the information that comes out of those organisations into how it applies into the dental setting. We're learning more and more about COVID, but we're also learning that COVID then springs up unexpectedly. And when it does spring up unexpectedly, then we've got to, I'll have to use Boris Johnson's phrase here, the whack-a-mole approach. So we need to be agile, we need to be flexible. We are in the process of, sort of, dare I say it, drafting up the guidance, but it's got lots of gaps in it because we don't yet have the and so what? And it's the moment that we can fling those and so whats into the blanks in the document. I can then start the tortuous process of pushing it through the NHS communications thing. And yes, that's been my biggest challenge. It's not easy, but we've got markers down. They know this is coming. We should be a little bit easier this time, but that's an element of fingers crossed on the NHS and what else they're putting out at the time.
Okay. So I think we will wrap this up fairly shortly, because I was going to say, your position carries with it a huge responsibility, and I think this crisis must have really increased that load, because it's been a really long haul for you over what is pretty much 6 or 7 months worth of this. So on reflection, looking back at all this time, is there anything that you would have liked to have been different?
Yeah, pregnant pause is a catalogue of things. You're not surprised. At the outset, we had a small team. We still have a small team, and we relied very heavily on what I call a strategy of pull, a pull of information. So we were posting our information on the NHS website. We were putting all the hyperlinks in there. We expected the profession to go to the website, which had been cascaded out through all the organisations, and we expected the profession to go and pull what they needed from the SOP, from the letters. And I think that we realised that actually the profession really wanted it pushed to them. And we didn't have the capacity to push information. And I can absolutely recognise why people have said that they don't feel that we've communicated. We certainly feel we produce a lot of information, without a shadow of a doubt. What we failed to do is push the information and communicate the information. As I say, some people have very easily adapted and pulled it. They've used it. And I can see that from the downloads that we have. I see that from the feedback that we have. And yes, maybe that's the majority of the profession have managed to do the pull. There's a vocal minority that don't seem to find what it is we've got out there, and they've relied on social media interpretation, and that's led to a degree of confusion. But I think we're getting better, and we're always ready to listen and learn about how to do things better. And I think one of the things we are doing better, and here and now today, just a conversation with you and I think this is a unique relationship between the CDO and the chair of LDC. Certainly in my 5 years prior to this, we didn't have this rapport. Maybe it's about Zoom, maybe it's about MS Teams. We mustn't lose this. No. We mustn't lose this connectivity with the LDCs. We mustn't lose their engagement. I meet with the BDA virtually twice a week. We've been holding workshops. I mean, we've got on our 10th workshop, and it's got 56 of the sort of top representatives from across the whole profession, from the technicians to the corporates, to the DCPs, to the BDA, to LDC reps. So Mickey Clark's on that for London, Will Newport. We've got better. We've got better. The information and communication is smoother. There's always going to be some people that don't quite get hold of what they need in the time they need. And I suppose I've seen the uptake on nhs.net, and that's going to be the real game changer, because with nhs.net accounts, whether you are entirely private, mixed practice, a DCP, a dental technician, nhs.net is available to you. And that is the primary way of us being able to cascade. So the moment something goes onto the website, I can send a hyperlink out, and we can push that way. I know it's different, and we've got the staff, well, hopefully got the staff to carry on that particular way. So yeah, communication.
Okay, well, it's been a real pleasure talking to you today, Sara, and let's do this again.
We will. Lovely.
Okay. All right.
Enjoy the rest of the conference.
Thank you. Bye.